Okay, perfect. So let's go ahead and get started. So good afternoon, everyone. Happy Friday. I hope everyone's doing well today. Thank you so much for taking your time out to join our echo session today. Before we get started, can I please have everyone take a minute to set their Zoom name as their first and last name, as this helps me with identifying who is on. Thank you. So if this is not your first echo session with us, then this will look familiar. This is the structure of all our echo sessions, starting with announcements, introductions, followed by a didactic session in which today's topic will be focusing on non-pharmacologic management of behaviors, and then we'll be moving on into our collaborative case discussion, followed by closing and reminders. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. And please always introduce yourself with your name and location prior to speaking. Maintain confidentiality when speaking about your clients by refraining from including any identifying information, and please respect others and their opinions. So we are CME accredited. Our main objective is to empower providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. Today's session is accredited for 1 CME credit. Certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. Many other licensing boards like the California Board of Nursing also recognize the CME for reciprocity. So our series is a part of the HCBS Dementia Careware Award, which is supported by the California Department of Healthcare Services. One of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care. Also to train geriatric specialists, primary care providers, and health profession trainees, and help expand our geriatrics workforce. So before we get started, we would like to have everyone take the time to quickly introduce themselves on video, but since we have quite a few individuals on the line, we'll go ahead and have everyone introduce themselves via the chat function if you can. When doing so, please list your name, role, site, and location. So in the meantime, we'll go ahead and have our hub team introduce themselves on video so you can get to know us. I'll get us started. My name is Nahel Khan, and I'm the project manager for our Dementia Care Aware project at UC Irvine Health, and we are located in Orange, California. So Dr. Segal, if you can please introduce yourself.
Yes, thank you, Manahil. Hello, everybody, and welcome. I'm Sonia Segal. I am a clinical professor here at UC Irvine in the Department of Internal Medicine and the Division of Geriatric Medicine and Gerontology, and I practice in Orange at our Senior Health Center.
Perfect. Thank you, Dr. Segal. So before we get started, I would like to introduce our presenter today, Dr. Miriam Galindo. Dr. Galindo is a licensed psychologist, social worker, and nurse with over 30 years of experience working in a variety of outpatient and inpatient mental health settings. A lifelong learner, she is currently completing a second doctorate as a nurse practitioner specializing in neuropsychiatric disorders and chronic conditions. Dr. Galindo is also a former longtime caregiver for her late father, Henry, who was diagnosed with Alzheimer's disease. And she shares a private practice with her husband, Dr. Jorge Galindo, and has been a proud volunteer for Alzheimer's Orange County since 2016. So welcome, Dr. Galindo, and thank you so much for taking your time out to give a presentation today.
Thank you. Thank you very much. It's an honor. So let's dive into this topic of strategies for caring for people with dementia with a focus on neuropsychiatric disorders. So if you could change the slide, thank you. The purpose of today's presentation is to provide information to you professionals on the basic overview of dementia, starting with neuropsychiatric features leading to behavioral changes, risk factors associated with changes, considerations for pharmaceutical versus non-pharmaceutical interventions, and then I'll conclude with a case study implementing non-pharmacological solutions. So let's start by defining what was once called dementia and is now called neurocognitive disorders. A major neurocognitive disorder, according to the DSM-5, generally speaking, is a diagnosis that's an umbrella term. And it's defined as a diagnosis where there's evidence of significant cognitive decline in one or more domains which substantially impair day-to-day activities. So specifiers now associated with syndromal patterns are distinguished by the etiology of the disorder. So for example, neurocognitive disorders due to Alzheimer's disease, frontal temporal lobular degeneration, Lewy body dementia, vascular disease, etc. So what we're going to be focusing on, obviously, is more than neuropsychiatric conditions associated with dementia. And although we can say that some of these cognitive deficits can present in conditions such as schizophrenia, in this case, we're looking at conditions with a core feature of cognitive impairment, cognitive decline. So we move on to the next slide. Alzheimer's disease is the most common cause of a progressive degenerative disorder, accounting for 60 to 80% of neurocognitive disorders. And so that's the one we're going to talk about the most. We see it the most, we hear about it the most. And the etiology, as you know, is cell death due to a buildup of amyloid plaques and neurofibrillary tangles comprised of tau protein. So as we all know, cell death accounts for the outward behavioral manifestations that we see. Now, this is something we all know, but when I speak to caregivers, it's something that I need to impart to them because it's hard to remember. Go ahead. Among the toughest of these behavioral manifestations for caregivers in particular is neuropsychiatric features. I divide neuropsychiatric features into two subcategories. One is dementia-related psychosis, and that would be the auditory visual hallucinations and also delusions. And then the other are neuropsychiatric symptoms like agitation, aggression, increased motor activity, restlessness. Risk factors associated with neuropsychiatric disorders include atrophic changes in the brain, ventricular enlargement, changed neurotransmitter distribution like acetylcholine depletion and dopamine changes. So for example, in Lewy body dementia or Parkinson's, dopamine might be depleted, but for example, in Parkinson's, levodopa can lead to psychotic symptomatology. So when you look at these before and after pictures on the right-hand side here, you see these atrophic changes. You see the normal brain above, you see the atrophied brain below. So the other risk factor is time and duration. In the later stages of dementia, you're more likely to see neuropsychiatric symptoms, although obviously you can see them throughout. But when you're seeing this level of destruction in the brain, it's more likely you're going to see these neuropsychiatric problems. Other exacerbating factors for neuropsychiatric symptomatology can be medically induced, like infections, when you see delirium. They can be substance induced, like the use of over-the-counter medications or other pharmaceuticals. They can be device induced, like, for example, if the person is needing hearing aids and they don't have their hearing aids or glasses. It can be the result of environmental overstimulation or deprivation. And we also need to consider things like psychosocial factors, like the relationship between the caregiver and person with dementia. Go ahead. So why are neuropsychiatric features important to know? Well, it goes without saying that persons with dementia who experience neuropsychiatric symptoms are distressed and they have a poorer quality of life. But it goes beyond that. Neuropsychiatric symptoms are burdensome to caregivers. They lead to an increase in hospitalizations and institutionalizations for persons with dementia. They lead to accelerated cognitive decline, and they're associated with increased mortality. And on that subject of morbidity and mortality, I want to add one more piece, and that's that there's ample research noting that dementia family caregivers are at very high risk of developing stress-related diseases directly associated with dementia caregiving, especially when it comes to caring for somebody with prominent neuropsychiatric features. So for example, in a study out of Stanford, it was found that 40%, or at least upwards of 40% of dementia caregivers died from stress-related conditions before the death of their loved one. Another study showed a correlation between caregiver depression and ED or hospital overutilization for loved ones with dementia. In other words, the neuropsychiatric symptoms in the dementia patient are correlated with caregiver depression, which then is associated with overutilization of emergency rooms and hospitals. So we're thinking not just about the dementia, the person with dementia, but we're also thinking about the family caregivers here. Okay, so we covered why dementia-related psychosis and other neuropsychiatric symptoms are problematic. Now we dive into what can we do about it. So I'm first going to discuss the pharmacological interventions, and then I'm going to talk about the non-pharmacological interventions. And then I'll spend the rest of the presentation focusing on the latter. So first, pharmacological interventions. Let's start with the bruiser. While the FDA is consistent in its supportive medications approved for the use of dementias, like Aricept and Namenda for Alzheimer's, for example, there are no medications approved by the FDA to treat psychosis or any of the other neuropsychiatric conditions in dementia. None. So here's the recommended protocol on the next slide. The first line of intervention is to address any behavioral symptoms in the person with dementia, and that would be non-pharmacological. And then once those are addressed sufficiently, then we consider pharmacological use. So now there's a lot of backing for this, and this is endorsed by several entities. For example, here on this slide, we've got the Centers for Medicare and Medicaid Services, who have proposed a mission promoting an increased use of non-pharmacological interventions over pharmacological interventions. And they cite a date of December 2019, which was their goal. The next slide, please. So this mission statement that was proposed by the Centers for Medicare and Medicaid is not just motivated by Pollyanna strivings, but rather legitimate health concerns. And you can see on this slide that the FDA has issued a black box warning linking atypical antipsychotic medication in elderly persons with dementia to heart failure, to pneumonia, and even to death. Next slide, please. Additionally, APA practice guidelines suggest that the benefits of antipsychotic medications are at best very small. By contrast, these medications are associated with clinically significant adverse effects. This doesn't mean their use should be banned, by the way. Rather, it's recommended that they be used cautiously at a low dose and only for a short term. I don't have it here on this slide, but there's a recent study out of UCSD described in the Journal of Clinical Psychiatry that looked at 4 atypical antipsychotic drugs. Let me see if I remember them. Aripiprazole, olanzapine, quetiapine, and risperidone, I believe. What this team of researchers found was that there were no significant differences among the drugs, and a quarter of the subjects, there were 332 subjects, developed severe adverse events necessitating hospitalization. And this included pneumonia, TIAs, serial agitation, and increased psychosis of all things. So next slide, please. So the current recommendation, again, is this. First line of intervention, caregiver education and behavioral interventions. Second line of intervention, judicious use of antipsychotic medications or pharmaceuticals in general for very specific behaviors involving imminent risk and only at a low dose for a short period of time. So now let's talk about the first line of intervention, which is behavioral interventions. Next slide, please. When we talk about behavioral interventions, we're essentially helping caregivers to view behavior on a continuum and to become more proactive rather than reactive. Essentially, we're wanting to stay in the green rather than finding ourselves in the red. Next slide, please. So our time doesn't allow us today to get into depth about a lot of these behavioral interventions. So what I'm going to do is summarize in a very condensed way how to approach problems when we're approaching them behaviorally. So the first step is we want to recognize precipitating factors. Dementia-related behavior never emerges out of nowhere. It's always for a purpose. There's typically an antecedent. So it's very important for us as caregivers and as instructors to caregivers to look at the context surrounding the behavior through the eyes and brains of our loved one. That's the important part. It's not through our brains, it's through theirs.
Oh, I can't stand it.
Next slide, please. Step 2, you want to observe for behaviors. You want to observe for patterns, excuse me. The patterns are central to the lives of persons with dementia. So what you're looking for then is what time of day did this behavior occur? Who was there? Who wasn't there? When did it happen? Where did it happen? You want to look at all these things that go into a pattern that reoccurs day after day after day, because the patterns are there. Next slide. Step 3, you want to be proactive rather than reactive. So after figuring out the precipitating factors to the patterns, you focus on prevention. So you want to stay in the green rather than waiting for the other end of the continuum to go all the way to the red. And in being proactive, you want to simplify the environment. You want to do things like cover mirrors or windows if indicated, because as you know, as persons progress through the dementia process, they may lose an understanding of themselves. So for example, their ability to recognize themselves in a mirror or recognize themselves in reflective glass is lost. And so they could become frightened by that. So you want to be aware of that. You want to reduce overstimulation, like too much noise, too many visuals, large crowds. And then you want to incorporate evidence-based interventions like music. And I'll talk about music as an intervention when we get to our case study. So once you rule out that the behavior is not induced by a medical cause or a substance, I would suggest think fear, because underneath a lot of the behaviors that you see in people with dementia, there is a lot of fear. And so one of the safest things you could do as a caregiver or instructor for a caregiver is ask yourself, what is making them so afraid? And that will help you see the environment through their eyes. All right, next slide. Step 4, when considering the interpersonal antecedents to challenging behaviors, you want to use compassionate communication. And again, you want to use it with their brains in mind. So you're dealing with someone who has a brain that is being subjected to progressive brain damage over time. What you don't want to be doing is using reason or logic or reminders or arguments or confrontations. You're not trying to get to the truth. You're not trying to convince them of the truth. What you're trying to do is diffuse the situation truly. And you're doing so with a lot of agreeing. You're doing a lot of distracting. You're accepting blame, you're apologizing. That's the stance you want to take, is understanding that they're coming from a fearful place, despite what you're seeing on the outside, which may actually look like a fight. All right, next slide. Step 5, the last step is just a reminder to all of us that there's a person in there. And as such, that person is worthy of dignity and respect. The best way to do that is to encourage independence and autonomy as much as possible, to the degree that it's safe, of course. And you're wanting to strive to replicate patterns and routines which are part of that person's former life. So that includes traditions, it includes religious activities, religious interests, replicating their morning routines, replicating the day-to-day routines, and as much as possible, bringing joy into each day for them. Next slide, please. And so we now come to our case study. I guess I'll read it. Here's the case study. Henry has mid-stage Alzheimer's disease. He's mobile and has lost his ability to express himself verbally. Henry needs assistance with toileting, shaving, dressing, bathing, and taking medications. Henry becomes physically and verbally aggressive toward anyone who tries to encourage him to take a shower. So I'm going to have a little disclaimer here. At the very beginning of this presentation, we talked about confidentiality. However, I also want something that's not just a fictional vignette. And so I want to assure you this is a true story. This is my dad. This is Henry's my dad. So when we talk about the application of interventions to this particular vignette, I want you to have a greater degree of confidence that these steps were tried and they were applied successfully. So what we're going to do, next slide, is consider all those steps that I just talked about. We're going to recognize the precipitating factors. We're going to observe for patterns. We're going to be proactive rather than reactive. We're going to be compassionate in our communication. And we're going to show dignity and respect to that person that's worthy of such. Next slide. So, you know what? Let's go back because I want to save this as a surprise. Can you go back to the last slide? Okay, so let me talk about these steps so that you have this as a visual, and then we're going to talk about the application of each of those steps. So I picked this subject for my behavioral vignette or my case study because it's actually a pretty universal phenomenon for persons with dementia, this resistance to immersing one's body in water. There's a lot of theories as to why. All I can tell you is when I'm doing caregiver instruction, I get a lot of feedback that this is a big deal. And it's a big deal for caregivers who are, trying very hard to help their loved ones. So here's the application of those steps. Before I do anything, before you do anything, you want to establish a goal from the outset. So my goal is that I want to impart more joy than not. I want to see this pattern shift. So what do I see? I see distress, I see agitation, I see physicality, I see punching, I see hair pulling, and it's all around shower time. And that's incredibly unpleasant. It's unpleasant for my loved one. It's unpleasant for me. It's unpleasant for any other caregiver that tries to take on this task. So that's the problem. And within that, I see a pattern. I see it's a negative pattern, and I see that if I approach this with force and aggression, I'm actually going to escalate the situation. I'm going to make it worse. I'm going to make it worse. And then it's going to repeat itself, and it's going to be worse and worse and worse every single time we try to repeat it. So what I want to do here is I want to flip it around. I want it to be a positive pattern, but I want it to be pleasant. I want it to be peaceful. I want it to be non-stressful for the loved one, and I want it to be non-stressful for the caregiver. So first, I want to take out whatever's feeding this fight. And so I'm going to tell you what I did and what I do with other people that I'm helping. And then I am then going to add something to reduce the anxiety, something to reduce the agitation, increase the joy. So we look at the precipitating factors. We want to look at the situation through his eyes and through his brain and through his distorted senses, because of course the brain is responsible for his sense of touch, his sense of smell, his visual sense, his auditory sense. All of those things are distorted at this point, presumably. And when I do that, I can imagine that someone with short-term memory is going to have trouble, and with receptive language problems and perceptual disturbances, is probably going to have trouble with that shower that's coming out of the wall. It's going to feel very threatening. It's going to feel abrupt. And so the best thing I can do is replace that with a handheld device. That handheld device also respects his autonomy and his sense of independence and a sense of control, which is going to alleviate some of that anxiety. The second thing I'm going to do is I'm going to look around and notice that I can replace dark mats with white mats. And the reason I want to do that is because I understand in watching his hesitancy around surface changes that his depth perception is probably affected and is probably distorted. And when I try to get him to step on that dark mat, he's going to react with fear because he's afraid he's going to fall into a dark hole. So I switch those out with a white mat. Plus, he's a baseball fan, so I can appeal to his baseball sensibilities and encourage him to slide into home base. The other thing we want to change is the communication pattern. So instead of trying to convince or talk him into it or explain everything, or even use the word SHOWER, we're going to use very short, confident directives. We're going this way. This is the way we go. Okay, right here. Step by step by step. Now, obviously, this depends on the stage, but we also have to keep in mind when somebody has a short-term memory loss, we can't expect them to remember long phrases. And if the word shower is alarming, it's counterproductive to use it at the outset. So we're gently, calmly, kindly, step by step, getting them in the direction we want them to go. So that's the precipitating factors. And now, after we want to do the proactive versus reactive. So when I establish a proactive stance, what I want to do is adopt an intervention that reverses the negative pattern, and I want to replace it with a positive pattern. And in doing so, I achieve a pattern that's more likely to replicate itself in the future with the least amount of stress for this person and for the caregiver. And in my case, and I offer this to a lot of people I instruct, one of the best evidence-based interventions I've found is music. It's not the only one. There are several others, but music has a lot of research to back it up. So that's the slide that I'm going to go to next. So I've got two studies here that I'm going to verbally share because there's some people just using their phones. And these are the studies I relied upon with my interventions, not only with my own dad, but with people I help, as well as a number of other studies that have supported this. In this particular study, which was quite extensive, a number of residents in a variety of different facilities were given music as an intervention. And the results of this particular study showed a significant decrease in the use of antipsychotic medication, a significant decrease in the use of anti-anxiety medications, a significant decrease in behavioral problems by 50.9 to 56.5% in the facilities using personalized music. And of course, we've got the comparison group where they didn't do these things and experienced mayhem. So this is pretty outstanding because what it shows is that music is just as effective, and I would argue maybe even more effective without the side effects of something that's pharmaceutical in nature. Look at this second study that's on the next slide. In this next slide, we've got a group of researchers who used iPods with musical selections, and they gave them to 108 residents in this memory care facility. And again, the results are similar. There was a significant decrease in transfer of residents to psychiatric facilities. There was a significant decrease in falls and physical altercations. There was a significant decrease in the number of one-on-one observations. And here's the bonus. Among the caregiving staff, there was increased morale, increased bonding among staff, residents, and families. There was increased teamwork, and there was decreased staff callouts. So we've got people who are not, presumably, we can infer that we've got low stress rates all the way around. And that's what we want to see, that we're recognizing that for every dementia patient, there is a silent patient, there is a caregiver or a team of caregivers who are also getting stressed out. And so So this is just a remarkable intervention. So to reiterate, we're looking at pharmaceutical and non-pharmaceutical interventions for neuropsychiatric conditions. What I've described in the preceding slides are a little bit about what we see with psychiatric disorders in persons with dementia. I've given you an overview of the pharmaceutical interventions, and then I've spent the majority of time on non-pharmaceutical interventions. So I'd like to give the audience a little bit of time to just maybe present some ideas, some thoughts, some questions, anything for our team here.
Hi, thank you, Dr. Galindo. So at this time, we'd like to open it up for any questions that you might have for Dr. Galindo, and please feel free to unmute yourself or put any questions in the chat.
Hi, can I ask a question?
Of course.
Okay, my name is Sharon Miller, and I have been running support groups for caregivers who have someone with a developmental disability and Alzheimer's. And one of the problems that comes off very often is yelling and sort of abusive behavior. And I wonder if you could speak to that a little.
Sure. I presume the yelling you're talking about is from the affected person?
Yes,
or are you talking about,
from the
it could be the caregiver.
Right, from the silent patient. No, I love that. From the person with dementia, just very kind of abusive, yelling, and not directed, not just kind of, and it's come up again and again, this yelling at night or yelling sort of out of control.
Yeah. Yeah. And the best thing I can suggest is that continuum that I had a couple of slides back, where we're looking at, red on the far right of the continuum, green on the far left of the continuum, and there's these yellowish areas in between. In other words, red is where you see that screaming, yelling, and abusive talk. Green is where we want to potentially intervene, or even at the yellow phase where we want to intervene before that agitation even starts. Because I assume that the reason your caregivers are bringing this to your attention is because when they try to intervene at the point their loved one is so upset and agitated that it's really hard to calm them down. Or as I described in that shower vignette, there's punching and hair pulling, as well as abusive language. So what we want to do with caregivers is try to get them to recognize that there's patterns. This is not just happening randomly. There's something that happens before, and it seems to happen in this way, and there's a pattern here. And so what can we recognize about that? Is it at night? Is it in the dark? Would having lights on help? So we're wanting to identify the problem to begin with, then look at precipitating factors, then look at, and patterns, and then try to figure out what is contributing to this. Is it something in the environment? Is it something that, the time of day, the time that they went to bed, all of these things before we develop a plan of intervention. And honestly, as somebody who works with persons who are caring for a loved one with dementia, and also somebody who personally walked that road, I can say that the more you think about the problem and look at it from all angles, the more the answer seems to emerge. But if you need an extra brain, we've got on this screen here a helpline for you, Alzheimer's Orange County, 844-373-4400, with people who are just delighted to take calls from anybody about anything during business hours, and help think this through so that the answer will emerge. So I hope that's helpful. I know it's not specific to one person in particular, but that's because I think it's so universal in nature.
Thank you, Dr. Galindo. So a
Thank
few
you.
more questions in the chat. So the next question is, any thoughts on using per need anxiety medications to help the person calm down in highly stressful situations?
Yeah, I think as I mentioned before, I don't think it's appropriate for us to just say, medication is bad. It's always bad. No, it's not always bad, because there are points in time where health and safety are at risk. For example, where a person becomes so agitated that they're going to hurt themselves or hurt you, and that you can't get their needs met because of this reaction. Now, having said that, we all know that a medication like a low dose benzodiazepine comes with some potential side effects, especially for elderly persons. It increases fall risk, it increases drowsiness. So we have to keep that in mind. But as I mentioned before, when there's a safety issue, we do want to open our minds to the possibility that an anti-anxiety medication judiciously used could be helpful.
Thank you. Another question, do you also have these topics available as handouts or infographics for patients and families?
I would love that. I'm deferring to UCI because they have these slides. So it's the property of UCI. But what I can assure you of is that our agency, Alzheimer's Orange County, provides education on a regular basis. And so you're certainly welcome to go on our archived educational PowerPoints and webinars and series that are available online. And you can see our website there, www.altsoc.org. And you can just help yourself to whatever's there. You can sign up for some of our educational trainings, and we're certainly happy to give you some of our handouts. But for this one in particular, I defer to UCI. They're the boss on what they do with this one. Thank
you. Another question, in addition to music, what other evidence-based interventions could we use?
Let me see. Now you put me on the spot. I'm trying to think of some of the ones that that I could have presented today. Honestly, there's been a lot on music, and so that's a biggie for me. And so when I've presented to my classes or even written papers on the subject, it's so prominent in my mind because it's so effective and it's backed by so much literature. But I know that, for example, singing, which I guess is a close relative of music, dancing or clapping, the rhythm, keeping time. I know that smells are very calming. So certain smells that are pungent, like ginger and celery and carrots and cookies and vanilla, there's the smells are, they bypass those regions that are damaged in the brain and goes straight to the calming, have some calming ability. The interesting fact about music is that, brain imaging shows that that portion of the brain that's responsible for recognizing and appreciating familiar music remains intact. It's as if it's insulated from the damage that's going on around it, which is pretty miraculous. If there's this little aspect of the brain responsible for appreciating and this familiar music, and it's insulated from the damage. So for that reason, I really, it's an amazing intervention, and it works.
Perfect. And then in addition to that, how do you best handle participants with exit-seeking behavior?
Oh, the restlessness. Is that what you mean? Like leaving the house?
I believe that's what they meant.
Okay. So, I mean, I suppose it's two, I can imagine this in two different settings. So exit seeking maybe to leave a facility or leave a group or to leave a home. So in a private setting. And, again, the first thing you want to think about is a behavioral strategy. So what you're noticing is this person is restless. They're physically restless. So no amount of reason is going to work. You can't say you can't leave because their whole body is screaming, I got to go. This isn't my home. And so, some of the clever strategies are you think through their brain. You look at things through their eyes. So, for example, do you remember I told you about for the shower, exchanging the dark mat for the light mat? Well, in the case of leaving the house, I'm going to put that dark mat right in front of the door, because if my loved one is afraid of a dark mat or stepping on a dark mat, I'm definitely going to use that to keep him from leaving. The other strategy that's been employed is putting locks higher up so that you can bolt the door, but it's not apparent to somebody who's not looking up, who's not realizing that the lock is higher. You want to think ahead, you want to think proactively. So you want to make sure that your person is outfitted with some kind of GPS monitor, because if they are restless, there's a likelihood that person will be able to get out. So you want to make sure you can retrieve them, you can find them again. You want to keep their hands and feet busy with other things. They're restless, so give them something to be restless about. So again, you're trying to think like them. You're trying to think empathically. This person's restless. Let me give them something so that they can get that energy going. And then, of course, you can also go with that. So, for example, scheduling walks so that they get some of that restlessness out in a safe way with you accompanying them on that walk. So when I was doing this, by the way, with the restlessness, is because earlier in the dementia process, you see that physical restlessness manifest in leaving the house, which is very alarming to caregivers. I experienced it too, so I know the feeling. But as the disease progresses and that person becomes more homebound or even more chair-bound or bed-bound, you still see that restlessness. It's in their hands. And so they're picking and picking and picking. And if you don't put something in their hands, they can pick their skin, they can pick their bodies, scratch their bodies. And so you see, things like busy blankets or little babies or little stuffed animals, so that their hands are, busy. They have something to do with that restlessness. So hopefully that helps. I know, again, I'm not speaking to your particular case because it is pretty universal. And if you have something specific that you want to talk about, I do encourage you to and welcome you to use the helpline.
Perfect. Thank you. And then one more question. Many times families come in with concerns regarding behavior problems and they have not paid attention to triggers. They come in asking for medications. How would you proceed in these situations?
I debated whether to actually put that in my slide presentation because as a medical professional who I'm intuitively thinking that's who you are, that's when we come to you, when we're stressed out. So you're not going to hear much from us until we get to that point. We might be a little concerned about memory loss, but then we go off and we can manage. It's when we see these neuropsychiatric conditions that we panic and we say, I don't think I can handle this anymore. And then we come to you. So it's at that moment, it feels like the city is on fire. From a caregiver's perspective, it seems like the city is on fire. And when a provider says, now look, have you already tried this? It can feel like you're patronizing me. Like, of course I've tried everything. But so my encouragement would be to get a person initially involved in something that's supportive in nature and educational in nature. For example, Alzheimer's Orange County, where there are groups that are devoted to education and support. And that way, these persons are surrounded by a help team of peers and of experts who can help guide them through those behavioral strategies. And that's not to say that you're saying, no, I'm not going to do it. But I think what oftentimes people find when their own caregivers find when their own stress level abates is that they can see straight and they can kind of problem solve and think through some of these precipitating factors, especially when they're surrounded by supportive people who say, I know exactly what you're going through. I was there once. Here's what I tried. And then the stress level goes down and you can think straight. Truly, the stress involved with caregiving is like none other. And the research emphasizes that unlike any other form of caregiving, dementia caregiving has a stress level like none other. And it's a destructive stress level. Like it can cause illness and it can cause even death in the caregiver. And it can cause a narrowing and rigidity in thinking where you're not even able to see the precipitating factors anymore. So you're not alone if you are in the medical profession and that's what you're faced with. You're not alone in that. We're coming to you because we're desperate. So I would just say, that again, that you're listening intently, you're saying, I definitely want to give that a try. And before we try, this is what I'd like you to do. I want you to at least go to one or two of these sessions and see if there's anything more you can do behaviorally. And then we'll talk about the medication.
Perfect. Thank you so much. Any other questions for Dr. Galindo? And again, please feel free to unmute yourself or put any questions in the chat. Okay, I believe that's it, Dr. Galindo. Thank you so much for your wonderful presentation.
You're welcome. And again, for those who are not able to see the slides that they've joined us by phone, can I just repeat that helpline phone number? Because it is so helpful for not only individuals who are caregivers of persons with dementia, but also professionals. And that's 844-373-4400. And again, I want to invite anybody, professional, individual, caregiver, people who are remotely interested to join us for any educational workshops or webinars over at www.alzoc.org, and that's spelled ALZOC.org.
Thank you so much. And I'm actually going to turn this over to Tony. Tony, would you like to go over a few resources?
Absolutely, because I do understand that some people might not be just here in Orange County, they might be other parts of the state. But again, like Dr. Galindo said, if you, we invite you to call us, send your families to us here at the helpline. They'll either talk to me or one of our team. We're all master level social workers, and we can really have the time to kind of process out their issues, their problems, and offer support, get them linked to different resources in the community. Here's some other resources in California. There's an Alzheimer's in San Diego, the Alzheimer's Association. Their chapter is in, they have one chapter in Los Angeles, but they're across the country. So if you are on this call in Kansas or any other state, you can just put that in your search engine, Alzheimer's, and any mid or large city, and it will show you your local chapter. I get a lot of great information out of the Alzheimer's Foundation of America. They're in New York City. It's a great website and a wonderful place for more information and support. So, that's I think another message we want to get to these families is that, yeah, this is tough stuff, but there's some really good support and help out there. So thank you, everybody.
Thank you, Tony. And thank you again, Dr. Galindo, for your presentation. And also thank you, Mark, for your help in this. So just to end off with closing and reminders, so if you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. I also did send these links in the chat, and I will also be sending a separate email with these links. We also ask that you complete the evaluation form, as this helps us with our continuous quality improvement efforts. This presentation and links will be sent in a follow-up email before the end of the day. And I will also be sending out a link to last week's recording. So both of these forms will close at 11:59 p.m. on Monday. So please try and submit these as soon as you can. And also please join us next Friday for our 8th ECHO session on the topic of high-risk medications that can contribute to cognitive impairment. which will be presented by Dr. Gurvich, and I will also send out a Zoom invite at the beginning of next week with more information. So thank you again for your time, and we hope to see you all next week.